Good morning. We stopped here in the last video, and in this video, I'll be focusing on the ECG strips that you might be encountering on the test and the valvular diseases. If I ever give you on the test a strip of ECG and whether ask you what this ECG strip represents, and justify your answer. So I might give you this strip, for example, on the test and ask you, what does this ECG represent? Meaning that I'm asking you to diagnose the condition that you see on lead one of that ECG strip. And of course, I'll always be asking you to justify your response. Or I might get you the ECG strip and you will have written on top of it or below it normal sinus rhythm, meaning that the diagnosis will be there and you will be asked to justify why this ECG strip represents normal sinus rhythm. Of course, the second option, this is the first option, you do both tasks, and this is the second option where you do only half the task, which is to justify, to give evidence why this is normal sinus rhythm. In such a case, I don't want you to say the rate is 60 to 90 because you have to define a rate. I don't want you to say the PR interval should be between 0.12 and 0.20. I'm not asking about the general characteristics of a normal sinus rhythm. I'm asking you in both conditions, whether in option 1 or in option 2, why you are saying that this is a normal sinus rhythm. What is the evidence that it is a normal sinus rhythm? So first of all, concerning the rate, you have to determine the rate. For example, assuming that we have here, for example, 1, 2, 3 big squares, and then we have like here 3 small squares and 2 small squares. So all in all, we have between the two QRS complexes, we have 4 big squares. So if you divide 300 by the number of big squares, which is 4, you will obtain 75. So I don't want you to say that in this ECG strip or in normal sinus rhythm in general, the rate is between 60 and 90 beats per minute. But I want you to say that in this particular ECG strip, I calculated the heart rate and it was 75 beats per minute, or it is 75 beats per minute. And this lies in the normal range, which is 60 to 90. You might be wondering why I said 3 big squares plus 5 small squares, which is another 1 big square. This is just because I'm opening the PowerPoint presentation on the slideshow, so I cannot enlarge the ECG picture, and therefore I can't see accurately the number of small squares. So I cannot divide 1,500 divided by the number of small squares. But of course, on the answer sheet, you would rather use this method because since you don't have an integral number of big boxes between two successive QRS complexes, then you had better use this method. Then you would say that the rhythm is regular, and you have to say why. So you would say that the rhythm is regular as evidenced by the constant duration of time between two QRS complexes. Of course, you can detect or deduce the duration of time or the time duration by counting the number of small squares, because each small square represents 0.04 0.04 seconds. So if you have, for example, between every two successive QRS complexes, you have 10 small squares, then you have 4 seconds. So the time duration or the duration interval is constant. Again, we have one P wave preceding every QRS complex. So here you have P wave, a P wave, another P wave, a third P wave, and so on. So for every QRS complex, you have a preceding P wave. So this is the third characteristic. And then when it comes to the PR interval, let's remember together what the PR interval represents. The PR interval represents a wave and a segment. So it represents the duration of the P wave together with the duration of the PR segment that starts at the beginning of the QRS complex. So I don't want you to say that the PR interval is normal and that's it, or the PR interval should lie between 0.12 and 0.20. I want you to tell me the exact duration of the PRS complex. The exact duration of the PR interval. Say, for example, that the width of the P wave was 3 small squares. This already makes 0.12. And then the duration of the PR interval was the PR segment was 2 segments, 2 small squares. So this means that we have another 0.8. So you count the number of small squares in the P wave, you count the number of small squares along the PR segment. So if we have 3 small squares for the width of the P wave, and 2 small squares for the PR segment, this makes a total of 5 small squares. And if you have a total of 5 small squares, this means 5 multiplied by 0.04 second, which means 0.2 seconds. So you would say that the PR interval in this ECG strip is normal because its length is equal to 5 small squares, and since every small square is 0.04 second, then the total duration is 0.2 second, and 0.2 lies in the normal interval. If it were 0.8 second, yes, it would also be lying in the normal interval. Not only this, but you have to prove that all, or to mention at least, that all the PR intervals are equal in length. Concerning the QR complexes, but before moving on to the QR complexes, there is something that's missing here on the slide concerning the P wave. You should mention, other than the P wave precedes the QRS complex every time, you should give a comment on the width of the P wave, and the width of the P wave should be less than 0.12 seconds. And if it is less than 0.12 seconds, this means that it should be less than 3 small squares. Then you have to test or to measure the width of certain P waves, not all of them, because usually they are equal in width. And you should say, for example, I found that the width of the P wave is 3 small squares, which means 0.12 seconds. And if it is 0.12 second for the P wave, then the P wave is of normal width. If you want to get a bonus, then you would also give a comment on the height of the P wave. The height of the P wave shouldn't be more than 2.5 millimeters, but this is an extra piece of information. You needn't memorize it. Similarly, concerning the QRS complex, first of all, they should all look the same. And here, this is important because if they do not look the same, then it would be ventricular fibrillation. The only condition you studied where you have the QRS complexes not looking the same is the serious arrhythmia, ventricular fibrillation. Here, you would say that all the QRS complexes look the same. And then you would find you would try to measure to calculate the number of small squares that form the QRS complex. And here, for example, if you have the Q wave, and then the R wave, and then the S wave, so the duration of the QRS complex is from the beginning of the Q wave to the end of the S wave, from the beginning of the Q wave to the end of the QRS complex, which is the beginning of the end of the S wave. So it should be less than 0.12 seconds. So you have to measure it. You have to count the number of small squares from the beginning of the Q wave to the end of the S wave and find if it is less than 3 small squares or not. And then you would also measure the QT interval, and the QT interval starts at the Q wave. You should know this well, because if you don't know what the QT interval represents, you would count a false number of small squares. So the QT interval represents the spread of depolarization and then repolarization over the ventricles. So it starts at the beginning of the Q wave and it ends at the end of the T wave, and it should be less than 0.44 seconds. For example, if you calculate or count, the number of, you count the squares in the QT interval, and you find that they are 10 small squares. 10 small squares means what? 10 multiplied by 0.04, which means 0.4 seconds. So it is less than 0.44 second, and it is normal. So when I ask you to justify why this is a normal sinus rhythm, or when I ask you to mention what rhythm this is and why you said this, you have to mention the characteristics you found on that specific ECG strip that is seen on the test. I don't want you to say that the PR interval should lie between 0.12 and 0.20. No, I want you to say in this ECG strip, the PR interval is so and so. So you have to count the number of small squares and every time multiply by 0.04 second to know the duration. As we said before, we can calculate the rate of the ECG strip via two methods. Either we divide 300 by the number of big squares between two successive R waves or R APCs, and we can also divide 1,500 by the number of small squares between two successive R peaks. So if you this is for regular rhythms. I will never ask you to calculate the rate in irregular rhythms, although we said this before. I'm not sure, maybe I would ask you to calculate the rhythm in atrial fibrillation. So I'll be reminding you how to do it in addition to the regular rate. So here we have a regular rate. Of course, as I said before, this is not one ECG strip. These are pieces of 5 different ECG strips, and that's why you find different rates. So if you have a regular rhythm, meaning that you notice that the distances between the R waves or the R peaks is the same, then you can use one of these two methods. Either you divide 300 by the number of integral big squares between the two successive R peaks, or you divide 1,500 by the number of small squares between two successive R peaks. So the choice depends upon whether between two successive R peaks, you have an integral number of big squares, then you refer automatically to this method. But if you don't have an integral number of big squares, meaning that, for example, between two successive R peaks, say, for example, like this, you have one integral big square, another integral big square, but here you have only three small squares. So this is not an integral big square. It is as if you had 2.5 big squares. So in such a case, since you don't have an integral, a round number of big squares, like one big square, two big squares, three big squares, but you have two and a half, two and a third. So in such a case, you had better count the number of small squares and not the number of big squares between the two successive ECG, two successive R peaks. I'll be postponing the irregular heart rhythm when we reach atrial fibrillation. Here, for example, we will apply the same. I'll not be repeating in order not to make the video too lengthy. You calculate yes. Here, for example, the diagnosis is sinus tachycardia. Once you look at the ECG, you might deduce automatically that this is a rapid heart rate because between two successive R peaks, we have two big squares, which means that the rate is 300 over 2, which is 150, and you have to write beats per minute. So the heart rate is 150 beats per minute. Here on the test, you cannot say that I found that the rate is above 100. No, this would be half the mark only. But if you want to take the full mark for that part of the question, then you have to say that the heart rate is specifically 150 beats per minute. Is it regular? Yes, it is regular. Why? Because we have two big squares between each two successive between two successive R peaks. So in such a case, since all the RR intervals are equal, we can simply say that it is a regular rhythm because all the RR intervals are equal. Concerning the P wave, you should say that we have one P wave before each QRS complex. What does this mean? This means when you have every QRS complex preceded by a normal P wave, this means that not only the rhythm has been generated in the sinoatrial node, but has also been normally conducted across the AV node to the ventricles. Here it's written simply that the P wave is normal. You might say that it is normal in width and normal in amplitude. Normal in width, so you have to count the number of small squares. So if you find that they are 3 small squares, then 3 multiplied by 0.4 is 0.12. So you would say that the P wave has a normal width because the width is equal to, you can say it in the unit could be squares or seconds. So you can say that the width is 3 squares or the width is 0.12 seconds. And as I said before, the amplitude is a bonus, or an extra piece of information. So you count the number of small squares on the vertical axis. Every small square represents a second. So if you have 2 squares and a half, so it would be 2.5 seconds, which is, sorry, not a second. Every small square represents 1 millimeter, and every millimeter represents a millivolt. So you just say that the height is 2.5 millimeters. And this is a bonus. And then we come to the PR interval. Again, you're going to measure the time duration between the beginning of the P wave to the beginning of the QRS complex. You would have the width of the P wave plus the width of the PR segment. From here, from the end of the P wave to the beginning of the Q wave, this is the PR segment. If you add to the PR segment the duration of the P wave, then all this is the PR interval. You can give it in squares. For example, we have here 2.5 small squares, and here we have 2.5 small squares. This makes a total of 5 small squares. And if it makes a total of 5 small squares, if you want to translate it into seconds, then it would be 5 multiplied by 0.4, which is 0.2 seconds. So I needn't, or I don't want to find on the answers that the PR interval is normal because it lies between 0.12 and 0.2. I want the discrete value of the PR interval, and you apply the same for the QRS complex. In sinus bradycardia, it's all the same, but the rate, of course, is different. So if you, for example, here, if we say that we have 1, 2, 3, 4, 5, and then these two together form the sixth big square. So the heart rate is around, it is around 300 divided by 6 big squares, which makes 50 beats per minute. So I don't want you to say that the rate is below 60, but why are we saying here the rate is below 60? Because 60 is the minimum heart rate obtained by the sinoatrial node. But actually here it is 50, even less than the lowest value of the sinus rhythm. But here this raises a question: is it actually sinus bradycardia, or it might be originating from the AV node, and it might be an AV nodal rhythm because the heart rate is really too slow, and even slower than the slowest rate expected from the sinoatrial node. And we will be deciding now whether it is sinus bradycardia or not. If it were an AV nodal rhythm, we wouldn't find normal P waves, because when you have a normal P wave, and the normal P wave is not only a P wave with a duration less than 0.12 second and with an amplitude or a height less than 2.5 millimeters, but a normal P wave. I'm now listing the characteristics of a normal P wave. The normal P wave is also an upright P wave. So this is important. So here all the waves are upright. Their duration is less than 0.12 seconds, which means less than 3 small squares, and their height is less than 2.5 millimeters, and they're all upright. Another thing that proves that this is sinus bradycardia and not AV nodal rhythm is the PR interval, because you know that if it were an AV nodal rhythm, the PR interval in case of the PR interval normally should lie between 0.12 and 0.2 seconds in normal cases. So if this is sinus bradycardia, then it would be between 0.12 seconds, which is 3 small squares, and 0.2 seconds, which is 5 small squares. You have to learn how to translate the time into a number of squares, because this makes your life easier. But if it were an AV nodal rhythm, then the PR interval would be shorter than 0.12 seconds, or it might be absent altogether. So here we have a good PR interval that is between 0.12 and 0.20. And again, you have, when you receive the sheet, you have to calculate the number of small squares. You will not tell me that the PR interval lies between 0.12 and 0.20. You would count the number of squares and you would say that I found, for example, 4 small squares representing the duration of the PR interval, meaning the whole length, the whole width of the P wave together with the PR segment. So from here to there. So this is the beginning of the P wave, and this is the beginning of the QRS complex. Again, of course, you would say that it is consistent, meaning that all the PR intervals are equal. Why is this important? Because in torsade de pointe, or when you have a prolonged QT interval, the PR intervals might not be equal. Again, you would comment on the QRS complexes that they are of normal shape and of normal duration. Normal shape means that each one of them consists of a Q, negative Q deflection, small negative Q deflection, tall peaked R wave, and then another negative S deflection. Here in atrial fibrillation, of course, once you look at the ECG strip, you can detect automatically that you have atrial fibrillation because of those chaotic P waves that are irregularly irregular, and the absence of the isoelectric baseline. The rhythm is irregular, as you can see, it's easily detected, and it is irregularly irregular, meaning that every RR interval differs in length from the other RR interval. So how can we know that the rhythm is irregular? By having variable durations of the RR intervals. And as you can see, it's chaotic. The P waves are chaotic, meaning that they are of abnormal shape, and they are irregular. They don't have a regular rhythm. There is no isoelectric baseline. But the QRS complexes have a normal shape and a normal duration. And if you want to know why they have a normal shape and a normal duration, this is because the ectopic, of course, here we have an ectopic focus. This is not a sinus rhythm. This is not a sinus rhythm. Why? Because it arises from an ectopic focus in the atrium. But after the ectopic focus has spread the impulses irregularly over the atria, they will be conducted via the AV node normally. So although we have an ectopic focus in the atrium, yet, and this is important to justify, yet we have a normal shape and a normal duration of the QRS complexes because they are normally transmitted or conducted via the AV node. So the QRS complex will be less than 0.12 second or 120 millisecond, unless, as we have explained before, we already have a bundle branch block. Because when you have a bundle branch block, this means that the AV node, instead of conducting the impulses equally across the right branch, right bundle branch, and the left bundle branch, this is a bundle branch, and that is another bundle branch. They are very specialized cardiac tissues that conduct rapidly as if they were nerves. So of course, when one of them is damaged, then the impulses here would be very rapidly transferred, and here it would be slowly transferred. So the right ventricle would contract more quickly and earlier than the left ventricle. So you would have two peaks of the QRS complex. The earlier peak belongs to the right ventricle and the later one belongs to the left ventricle, but I'll never ask you to explain this. Okay, so then remains the rate. Here we have, of course, an irregular rate. You cannot calculate the atrial rate. Yani, I don't want you to say that the atrial rate is around 300 because you will never be able to measure it. But I want you to calculate the ventricular rate because the R peaks are very visible and very accurate. In such a case, we should refer again to the small squares. Every small square is 0.04 seconds, and every big square is 5 small squares. So the big square is 0.2 second. And if you count, this is the big square. The duration of the big square is 0.2 second. So if you have 15 big squares, then you multiply by 15, then 15 multiplied by 0.2, 15 by 2, this makes 30, by 0.2, this means 3 seconds. So every 15 big squares form 3 seconds. So when you count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So from here to there, this is 3 seconds. And usually there is a mark like this. If you have another mark here, this means that you have another 15 big squares, and that makes 3 seconds. So the total is 6 seconds. Why is this important? We are just trying to make your life easier. Because the rhythm is irregular, I cannot apply 300 divided by the number of big squares. And because the rhythm is irregular, I cannot apply 1,500 divided by the number of small squares. But what I do is to count 30 big squares, which is usually an easy task because you have those marks. And every 2 consecutive marks include between them 15 big squares, or simply count 30 big squares. 30 big squares make 6 seconds. And then after having determined the beginning and the end of the 6 seconds, you count the number of QRS complexes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. So I have 12 QRS complexes, which means 12 cardiac cycles per 6 seconds. This means what? In 60 seconds, I will have 120 beats per minute. And 60 seconds is, why did I say per minute? Because 60 seconds is 1 minute. So again, to wrap up all this, whenever you have an irregular rhythm, you determine the beginning and the end of 30 big squares, which means 6 seconds, and then you count the number of QRS complexes if they are well determined, like here, and you say that I have, for example, 12 QRS complexes per 6 seconds, so I will have 120 per 60 seconds or per minute. Here you can notice what? You can notice that the ventricular rate is much slower than the atrial rate. Here, I'll never ask you to precisely determine the atrial rate, but it's usually between 350 and 600. So it's usually higher than 300. So if the ventricular rate is 120, this means that the AV node has slowed down the rate. So here, for example, the ectopic focus is beating at 360 beats per minute, but the ventricles, according to our calculations, beat at 120 beats per minute. So this is the job of the AV node that has been well done, which is to slow down the rate to protect the ventricles and to give them enough time to fill with blood and contract. In such a case, we can say that there has been a 3-to-1 block because we have reduced the number of waves that reach the QRS complex to 1/3. Atrial flutter should have been discussed first because atrial flutter is a more regular rhythm. Of course, we will do the same thing. Here you can easily see that it is a regular heart rate, and you have to say that it is regular because the RR intervals are all equal, and you had better mention the number of small or the number of big squares that exist between them. And then you will calculate the rate. And usually that rate that we calculate, like here, for example, 300 divided by 2 big squares gives you 150 beats per minute. That rate that we calculate is usually the ventricular rate. Here it is possible to calculate the atrial rate, but it's much easier to mention that we have, for example, let's assume that the atrial rate is 300 beats per minute. Then there was a 2-to-1 block actually, because the ventricular rate here is 150 beats per minute. I will never ask you to calculate precisely the atrial rate in atrial flutter, because sometimes it's difficult to determine where the P waves are, because you can never know whether this, for example, is a P wave or a wave of repolarization of the ventricles. So I will never ask you at the level of grade 11 or 12 to calculate the rate of atrial flutter. Let's assume that it is 300 beats per minute. Actually, if we want to calculate it precisely, if we assume that this is a P wave and that is another P wave, then because they are similar to each other, I'm trying to select two similar P waves. So this is a P wave and this is another P wave. And the number of big boxes between them, the number of big squares, I can see well, so I'll not be able to calculate. So what you do is to divide 1,500 by the number of small boxes between the two successive P waves, or divide 300 by the number of big boxes. Most probably you will find that it is around 300, but you can accurately calculate the QRS, the distance between two successive QRS complexes, and the rate is around 150 beats per minute. And you mention the block that has occurred. In such a case, the block is a 2-to-1 block. One of the characteristics of atrial flutter, so first of all, you have to say that it is regular. Number two, atrial is important to mention, because although it is an ectopic focus, it's not a sinus rhythm. Of course, atrial flutter and atrial fibrillation are not sinus rhythm, but they are still originating in the atria. And then you mentioned the atrial rate, you mentioned the ventricular rate, you mentioned the ratio of the block, and then it is important to mention that the QRS complexes have normal shape and normal duration. And again, how can we, in case of atrial flutter, obtain QRS complexes of normal shape and duration? It's the same answer. This is because they have been conducted across the AV node, and this is a normal pathway. And since it is a normal pathway conduction, then the QRS complexes have normal shape and duration. Here, of course, we don't have an isoelectric line. We can't see the zero line. And here in atrial fibrillation, we describe the P waves as being chaotic, but in atrial flutter, they have the sawtooth pattern. This is, of course, ventricular flutter. How can I detect that this is ventricular flutter? First of all, it is a very rapid rate. Second, it is a regular rate, as indicated. Again, every time you say regular, that you have equal RR intervals. So it's a very rapid rate. It is a regular rate, and there are no visible P waves. There are no visible P waves. Don't say that there are no P waves, because if you say no P waves, this means that there is no atrial depolarization. And this is absolutely wrong, because in such a case, the SA node is working normally, but there is an ectopic ventricular focus that is taking over. So when you measure the pulse rate of the patient clinically, or when you measure it through the ECG, it's the rate of the ventricles that is overriding the rate of the whole heart. So there is atrial depolarization, but it's not seen because it is masked by the QRS complexes. Furthermore, of course, since there are no visible P waves, so there are no PR intervals. Furthermore, the QRS complexes are different. They do not consist of QRS complexes. They are just sinusoidal waves. So there are no QRS complexes, but there are tall sinusoidal waves. So again, it's a rapid rate. It's a regular rate as indicated by equal RR intervals. There are no visible P waves. Of course, since there are no visible P waves, there are no PR intervals. We cannot identify Q waves nor S waves, so we don't have QRS complexes. We have tall sinusoidal waves. The most common cause is ischemic heart disease, not enough oxygen reaching the myocardium. You can easily detect the rate because in such a case, you can determine the R peak and another R peak, and you count the number of small squares in between them and divide 1,500. So again, I don't want you to say that the ventricular rate is 250 to 300, but I want you to say that I counted. So you first count, and then you calculate in order to have a measurable RR interval. So you count the number of small squares here because the distance is very small between them. And then you calculate the time because you will take the number of small squares and you multiply it by 0.4 to calculate the interval, the RR interval. But you needn't do this. You can just divide 1,500 by the number of small squares that you counted, and you get the ventricular rate. Of course, ventricular fibrillation is obvious because this is, first of all, an irregular rhythm. Why is it an irregular rhythm? Because we have unequal RR intervals or irregular RR intervals. There are no QRS complexes. They are bizarre shaped QRS complexes. There are no visible P waves, of course, and therefore there are no PR intervals. You cannot see, for example, a T wave, and it is a very rapid rate. The cause is the presence of a focus, an ectopic focus, of course, in the ventricles, and the rate is around 300 beats per minute. In this one in particular, I'll not ask you to determine the rate because you can just say around 300 because of course you can count it with the same way you counted atrial fibrillation by determining the number of QRS complexes in 6 seconds and then multiplied by 10 to obtain in a minute. But the problem here is that this, for example, bizarre shaped QRS complex and that one, you cannot know whether this is one. Let's take this example, for example, because it's very clear. It's a very clear evidence that we cannot count from the ECG. Here, for example, this one. You cannot know whether these are two separate peaks, two separate QRS complexes, or is it one bifid QRS complex, one split QRS complex. So I'll never ask you to calculate the rate. You can just say that it is an irregular rhythm as indicated by unequal RR intervals. This is most probably ventricular fibrillation because you have bizarre shaped QRS complexes. The rate is very rapid. The rate is irregular. There are no visible PR, no visible P waves, no visible PR intervals. The QRS complexes all differ. They're not only bizarre shape, but they are different from each other. They differ in shape, they differ in amplitude, and they differ in duration. This is very important. The last statement is very important. In the AV nodal rhythm, this means what? Why is this AV nodal rhythm? First of all, it's a regular rate, as indicated by equal RR intervals. Second, it's a slow rate. So it's a slow regular rate. So for example, we can say that we have 1, 2, 3, 4, 5, 6, 7, around 7 big squares. So if you divide 300 divided by 7, so you would have, for example, 43 beats per minute, which is a very slow rate. Moreover, you have inverted P waves before each QRS complex, and of course, the PR interval is very short. But again, this is very important. This last statement is very important. The QRS are normal in shape, normal in duration on the x-axis, and normal in amplitude on the y-axis. So you don't say normal and that's it. Normal in shape, normal in duration, normal in amplitude. And again, as we've said before several times, why are they normal? Because they were normally conducted across the AV node, normally conducted along AV node. Is it a sinus rhythm? No, this is not a sinus rhythm because it originated in the AV node. How come that it originates in the AV node and meanwhile is normally conducted via the AV node? It's very simple. If we have here the two atria and the two ventricles, and we have the AV node here. So suppose you have an ectopic focus here at the top, for example, of the AV node. So the ectopic focus will generate impulses, and those impulses will descend normally and will be conducted normally across the AV bundle and then across the bundle branch to be normally transmitted to the two ventricles at the same time. In valvular diseases, it's very important to know the characteristics of every condition. In mitral stenosis, we have a narrow mitral valve, so we will have difficulty of flow of blood during diastole from the mitral valve from the left atrium to the left ventricle. Why? Because here we have a narrow valve. So stenosis means narrow. And if the valve is narrow, then the blood flow will not be laminar. We will have turbulent blood flow. And if we have turbulent blood flow, then we would have a murmur. And since this murmur occurs during passage from the left atrium to the left ventricle, when the left ventricle is relaxed, meaning when the left ventricle is in diastole, then the murmur will be heard during diastole, and it will be a diastolic murmur. So it's worth noting that this murmur is diastolic. And where is it best heard? Over the mitral area, because it originated in the mitral valve, and diastolic means between S2 and the next S1. So in mitral stenosis, we have a narrow valve, we have turbulent blood flow, and we have a murmur that occurs during diastole. So it is a diastolic murmur, and that diastolic murmur is best heard over the apex or the mitral area, which is the fifth intercostal space, left mid-clavicular line. And a diastolic murmur means that if we have S1 and then S2 and then another S1, then the diastolic murmur would be here. In case of mitral let's first consider tricuspid stenosis. All what we said on mitral stenosis applies to tricuspid stenosis, with one difference is where you can best hear. So it's only the area of auscultation where you can best hear that makes a difference. But you have a murmur, you have a diastolic murmur that is best seen over the tricuspid area. Where is the tricuspid area? Fifth intercostal space on the left sternal or at the left sternal border. In mitral regurgitation, on the other hand, we have an incompetent valve. What do we mean by incompetent valve? It's either a wider than normal valve or a distorted valve. In all cases, this means that the valve does not close properly. When do we want it to close properly? During left ventricular systole, because we are here considering the mitral valve. So if it does not close perfectly during left ventricular systole, there would be backflow of blood during systole. So there would be a systolic backflow. And if there is a systolic backflow, then there will be a systolic murmur. Where is it heard? Again, over the apex, because we are considering mitral regurgitation. So in mitral regurgitation, if this is S1, S2, and then another S1 and another S2, so systolic means between S1 and S2, as we said before. So the murmur is a systolic murmur, best heard over the mitral area. Similarly, tricuspid incompetence is exactly the same, an incompetent valve that allows backflow of blood, but this time during right ventricular systole. So you would again have a systolic murmur, but because this systolic murmur originates in the tricuspid valve, so it would be best heard over the tricuspid area, which is the fifth intercostal space, left mid-clavicular line. In aortic stenosis, there is difficulty for the blood to pass from the left ventricle to the aorta. Of course, when does the blood pass from the left ventricle to the aorta? During left ventricular systole. Why? Because the valve is narrow. The valve is stenotic. So we would have turbulent blood flow during systole. And since we have turbulent blood flow during systole, then we will have a systolic murmur. But where do we best hear this systolic murmur? Over the aortic area. Why am I saying best here? Because you can hear it over the whole chest. You can hear it over the aortic area, over the pulmonary area, over the apex, but you can best hear it over the aortic area. Why do we best hear it over the aortic area? Simply because it originates in the aortic valve. What is the aortic area? It is the second intercostal space to the right of the sternal border. The same applies to pulmonary stenosis, but this time there is difficulty for the right ventricle to pump blood into the pulmonary artery because of a narrow pulmonary valve. And of course, the problem would appear during systole again, and the turbulent flow would appear during systole. So it would be, again, just like in aortic stenosis, a systolic murmur. The only difference would be where is it best heard. It is best heard over the pulmonary area, which is the second intercostal space to the left of the sternal border, or at the left sternal border. So simply left second intercostal space. Last thing, we have aortic incompetence. And in aortic incompetence, as you can see, the valve is incompetent. The aortic valve is incompetent. So when the left ventricle starts to relax, there is backflow during diastole. So there would be a diastolic murmur, and that diastolic murmur is there because there is turbulent blood flow due to backflow during relaxation. And that diastolic murmur means what? Between S2 and the next or the following S1, and it is best heard, of course, again, over the aortic area. Last thing to say is pulmonary incompetence, and in pulmonary incompetence, there is the same. There is backflow of blood. There is incompetence of the pulmonary valve. There is backflow during diastole, but this time during diastole of the right ventricle. And therefore, you will hear a diastolic murmur, but this time over the pulmonary area, second left intercostal space. Thank you, and I wish you the best of luck on your test tomorrow, inshallah. And if you need any question, of course, send me on WhatsApp.